So it's my role now to coordinate the wrap-up of the day. And I'm joined here by Francesco Maisano in London and also by Nicole in Paris, who you've seen earlier in the day. Nicole, could you give me some key take-home messages about the first half of the day in the sessions that we had in the morning?
Yeah, hello. The first part of the day was very rich. We had a first part that was related to imaging. And in this imaging part, we have a nice talk from Victoria, who really insisted on the importance of distinguishing primary and secondary MR. And this would be important for the rest of the day, because we will see it later with the others. And then we had Ronak, who really introduced the idea of multimodality imaging and the importance of CT, aside of explaining to us how to prepare and for a potential mitral intervention. So those two sessions on optimal imaging were really important. And then we moved to an interesting session, which is in line with the last hotline that we saw, which was from Bushra, who showed us an outstanding case where we had a patient with a valve and ring procedure that almost went wrong. And here it was so rich of information and of tips and tricks. It highlighted against the importance of really optimally sizing of the valves that you want to use inside the ring, and the importance of really anticipating the potential of LVOT obstruction, whether by looking at the cavity size, at the length of the anterior leaflet, and of the annular annulus, the angle between the mitral and the aortic annulus. So those parts were really interesting in the imaging session. And then we moved to the spotlight. And in the spotlight, we had two interesting presentations on primary and secondary MR. And this time it was very important to see, again, the wide choice. The discussions were very important because first we had the introduction of the wide choice of clips that we had. And we still remember when we only had the MitraClip and only one size, and now we have a wide variety. And again, we can choose now and we can tailor our treatment. And here we had important information regarding the need for a meticulous analysis of the anatomy. And it was important also to listen to the discussions regarding the new potential applications of MitraClip, particularly in cardiogenic shock and in acute heart failure. And here again, those were important discussions. And then we moved to a live case. And that live case was performed in Toulouse, a very smooth and nice case that went straight forward. And it was interesting to hear the introduction of the case by Nicolas Timontet and Didier Cheche. They really explained something that we all see in our daily practice with this, which is the limitation of scores. I mean, we know the STS score, or score, but at the end of the day, we have one patient, his frailty, his comorbidities, and the importance of seeing what I can achieve as an interventional and what the patient needs according to his age. And this was very important. And for the rest, we had lots of tips and tricks all over this case to see how to manage the patient, how to really manage the clip and orient it correctly. And the discussions regarding the importance of putting two clips for safety reasons and for optimal reason were very important. And again, they sent us back to the presentations of Victoria in the morning, who really explained the importance of careful analysis of each segment of the mitral. So that's for the morning. What about you? What about the afternoon?
Well, I agree. The MitraClip case, Didier and Nicolas, beautiful case. And there would be many MitraClip operators that may have left that small prolapsing segment and small mitral regurgitation, but hearing their reasoning to put an extra clip in was really fantastic. The afternoon got a little bit more surgical, and that's why I'm glad I'm joined by Francesco here. But we started with Volkmar Falk giving a very brief overview of the surgical techniques. And for me, as an interventional cardiologist, it was a reminder of how much more surgeons can do at the moment. We're still a long way behind in terms of what we have to offer with transcatheter therapies, but a very, very succinct summary of fully endoscopic techniques achieving really fantastic results. But we went on to look at the very newest mitral devices with Paul Saraja and gave an overview of the state of the art. It seems to me that in this field, we've all known it for some time, but in this field, we're now moving to fully percutaneous. So we are using transeptal devices rather than transapical devices. And I think that's inevitable, that we now need to move on with looking at fully percutaneous mitral devices rather than the transapical approach. And then we went on to an area which I think that surgeons and cardiologists often forget a little bit about, but it's the importance of heart failure. A very, very excellent summary of heart failure from Bill Abraham, who got into a discussion afterwards about the sequence of treatment. And I think it's a really important point that you shouldn't just take a patient one by one through these various treatments. You should take them in parallel quite often. So there's no reason why we can't be thinking about structural interventions when someone else is up titrating the medications, when electrophysiologists are involved in the application of CRT. So I found that a good reminder that we've got to be a bit more agile in our management of these heart failure patients. And we went on then to a very, very elegant surgical repair of the mitral valve, which again just reminded me of how much more surgeons can do in terms of caudal repair and leaflet resection. And we heard a lot of talk about caudal replacement. And I think, Francesco, I'd like to bring you in to ask your view on maybe what is the most important aspect of surgical repair. Is it the cords? Is it leaflet resection? Is it the ring? You're going to say all of these 120 techniques.
Well, there is a big difference between what you need to achieve in surgery compared to interventions. When you operate on a patient, even if it is a minimally invasive approach with fully endoscopic, which is today standard of care in high volume centers, still you want to be definitive. You want to have the best outcome possible, has to last forever. And that's the reason why a surgeon cannot afford to skip one step. So I think we keep this concept of managing both leaflet disease and annular dilatation. And obviously, in this particular case, we have seen 3 procedures or 3 techniques at the same time. There's been a chorda repair. There has been annuloplasty as standard, but also we have seen edge-to-edge, which has been elegantly solving a problem, which is the commissural prolapse, which was evident at the end of the procedure and was probably a bit overlooked before. This happens pretty often in these patients, and with a simple stitch, it was solved. And again, this shows how this leaflet repair using the Alfieri original technique has a big role both in surgery and interventions. In general, I think anyhow, surgery comes from more than 50 years of experience.
Yeah.
And interventions is still in the early stage, but what I've learned today in the old days is that we are not anymore in the pioneering phase. Data are coming. The data are every day more sophisticated, and I think that what we are seeing, that we start to have more evidence to support our decisions.
And I think a session like this emphasizes that we get the best results from our patients when we work together. I think it really is very much a combined thought process, a combined planning operation, a combined sequence. We use our other colleagues to optimize, and we do what's right for each individual patient. I think we're moving into this precision medicine phase now, era, where we tailor treatments at the right time and do it together. So I think this session emphasized the need for that. The live case was also interesting because there was lots of comment about the degree of left ventricular impairment. And I really felt with that discussion that we didn't have much data. And Bill Abraham said, there's never been a study convincingly shown that surgery in secondary MR does any good. So it's very much a clinical call. The heart team in Leipzig made the call very successfully. But there was questions from the Johannesburg pod about, how bad does the left ventricle have to be? With no data to guide us, what do? We've just got the heart team, haven't we? We have to make a clinical call.
Yeah, I mean, the decision in Leipzig was a decision that maybe in other hospitals would have been different.
Yeah.
And I think this is at the end also the spirit of PCR. I don't think there is any dogma here. You need to adapt your decisions to your local expertise, your local resources, your tradition. And again, once more, today was the opportunity to see the full spectrum of options, which again underlined the fact that we need to be open-minded because there is much more than what we are doing every day. There is a lot of things going on, and the scenario will change over time. So we need to be prepared for this change.
And we learn from each other the whole time.
Absolutely.
And I've learned a lot today. Nicole, what do you think about these hotline sessions? I mean, really cutting edge. These are cutting edge interventions, really. We talk about them as if they're day to day because we're a selected group. But these are cutting edge interventions. Tell me what you thought about the EXPAND study, which is really expanding these new, more sophisticated MitraClip devices into what we call a real world population and getting really good COAPT-like results.
Absolutely. The EXPAND trial is providing us with very, very good results, and it's so encouraging. Today we will wonder if, we probably will want to enlarge the population we are addressing. And in that study, for me, it was very important to see this comparison between the patients with EROA of less or more than 0.3, because we've all heard these discussions after COAPT and MITRA-FR to see whether we should treat those patients or not. So I guess here, and this is something that we also discussed this morning with Victoria and with Fabienne, because we always keep on asking ourselves these questions related to whether we should preclude the treatment from patients with lower ERO values. And after the EXPAND studies and the sub-analysis that they provided, I really feel like we shouldn't preclude and we should expand, as the study is called, expand the treatment to more and more patients and feel more and more confident with providing this treatment to more patients to enlarge the population.
And talking about expanding, we're expanding the device options by the Dragonfly. So a very elegant, early feasibility study with a Dragonfly, which looks like an interesting device. And I've always said that the more devices that we have at our disposal, the better that our patients do. I think if we should now really be getting into an era where we tailor devices to individual patients, to individual anatomies, and I welcome all devices because we all know they have little nuances which make them easier to use in some patients, and then we can choose the precise device for our patients.
Absolutely.
I was curious by the last hotline study, which was the valve in ring, valve in valve, and valve in MAC. I mean, I was surprised that the valve in MAC did so well. Were you surprised by that? Because I had always had in my mind that valve in ring do best. Sorry, valve in valve do best, valve in ring do a little bit worse, and valve in MAC do the worst. But Myra really showed us that's not really the case. And with well-selected patients, you get quite good results in valve in MAC scenarios. Were you surprised by that?
Yeah, absolutely. I do agree with you. The key is in the selection of the patients. But I remember doing a session in London Valve with Nicolas Dumontail just 1 year ago, and the session was entitled Mitral Valve in Valve or Valve in Ring. It was entitled The Good, the Bad, and the Ugly. And the ugly was supposed to be the valve in MAC. And today, I'm not sure that we would give the same title to the session. Because obviously, the valve in valve is not the good, it's the very good. The valve in ring, maybe we'll position it, I don't know if you agree, like a good. And I'm not sure anymore that we are allowed to call the valve in MAC the ugly, but it's still a challenging technique. I mean, we are talking about a selected population, as you said.
Yeah. A 10% stroke risk should not be discounted either. A 10% stroke, which is pretty high. I think, I don't know whether you agree, these are surgical turndowns for sure. It's compassionate use for sure. challenging. I think Myra gave a hint that really expert center, brilliant imaging, brilliant experts, they select their patients very nicely.
Absolutely. You know, the bad, the good and ugly is the editorial that we wrote after we saw this paper from this first initial data from Myra, and obviously these results are highly due to selection. We learn how to select these patients, which is not something new. I mean, we should not overuse a technique. We should adapt our techniques to our patients, and that is always key. So again, it's about everything.
And going back to our former comments, it's about teamwork with our heart failure colleagues, our imaging colleagues, and our surgical colleagues. And sometimes we are faced with patients who have no other options, and we have to do our best for them.
Absolutely.
Absolutely.
So I think the time is now coming up to the end of the day. I would like to thank all of our speakers and our live case operators today on behalf of the PCR family. Really a spectacular day, cutting edge interventions presented in a very educational and collegiate way all the way through. I would just ask all of the viewers at the moment not to log off now, because there's two extremely interesting sessions coming up. There are some sponsored evening sessions from Abbott and Edwards Life Sciences, and you can navigate on the website into those sessions at the end of this session. So please don't log off, and make sure that you avail yourself of those two sessions. So I think it's time to close. And I'd like to thank my studio friend and colleague, Francesco, and Nicole, who's done a brilliant job from Paris, and everyone else around the world. So thank you very much. Have a very nice evening.
Thank you.
Bye-bye, Paris.
Bye.
Bye.